maybe a minute more, and then we'll get going. All right, so we are going to get started. Good evening, everyone. Thank you very much for joining for what's going to be an exciting evening with electrophysiology and introducing one of the legends in electrophysiology. But before we get our presentation going, let me just introduce also our customary steps to get through the CME and the MOCs. For this, again, you have an opportunity to claim the CME and MOCs. Usually we have all the presentations lined up on the YouTube channel, which are being very well sought after. And for today's CME, please text 20378, number 888-816-4893. And as an SMS message, 20378 to the number 888-816-4893 to claim your CME credit. And if you're a physician, you have the room code future52 with the link that will be again displayed back in the chat box and will be available for the next 12 hours after the presentation for you to go ahead and answer the quiz correctly, and you then get your MOC points directly going to your ABIM in your Cloud CME profile. All right, so with that, it's my great honor and privilege to bring forth and introduce you to Professor Melvin Scheinman. Dr. Scheinman is a true legend and pioneer in electrophysiology. He was one of the first persons to perform cardiac ablation in humans. And his team also developed the radiofrequency energy ablation for arrhythmias. His professor and currently directs the genetic arrhythmia program at UCSF. And he's been principal investigator also at the DEPS Foundation for the Genetic Arrhythmia Program. Dr. Scheinman grew up in Brooklyn, New York, and underwent his undergrad at Johns Hopkins, then did his medical education at Albert Einstein, residency at UNC Chapel Hill, cardiology at UCSF Medical Center, and subsequently has had distinguished position in academics and research in for several years. He was the chief of the electrophysiology section from 79 to 97 at UCSF, and he has had distinguished position at the NIH and several national societies like NASP, Heart Rhythm Society, and ACC, through which he has contributed enormously to education and research in electrophysiology. He has tons of awards and honors to be recognized for his role, which include Gifted Teacher Award from the American College of Cardiology, Outstanding Clinician Scientist Award from ACC, and many more to come. He's an editorial and review board member for several esteemed journals. He has over 600 publications, over 80 textbook chapters, and he has probably contributed to careers of several electrophysiologists and academic cardiologists and shaped the field of cardiology in the nation and worldwide. With that, we welcome you, Dr. Scheinman. I know the last time you tried to join us, you were somewhere in Italy. You were caught up in a flight that was a little bit of a problem, but I'm so glad that you are here today. And joining today as panelists, we will have Dr. Ted Maglione and Dr. Costas. And I'm also very thankful that we have Dr. Jim Koromolis, who has joined in. I'm seeing him in the audience. He's a close friend. And I think Dr. Koromolis recommended Dr. Scheinman's name in the beginning because of his common interest in the field of genetic cardiac arrhythmia. So if time permits, maybe we will also have Dr. Karamelis come and join us in the panel and provide some conversation on this important topic. But today's topic is going to be on AV block, and we are really interested to hear what you have in store for us. The floor is yours, Dr. Scheinman.
Okay, well, thank you so much for that marvelous introduction. I really appreciate it. Today, we're going to talk about the AV blocks and emphasize diagnostic techniques and some exciting new treatment techniques for this disorder. These are my disclosures. I also have another disclosure.
We are not able to see your slides as yet, Dr. Scheinman. Sorry for interrupting.
Can you see the slides?
No, we are not. So would you want to just reshare it?
Okay. Okay, are we all right now?
Not as yet. No, we are not as yet.
Yeah, okay, I'll just make it larger. Here we go. All right. So
it's still not up in the
yeah, these are can you see it?
No, we are not. We're just seeing Navina, are you able to see? Do you think we are good or we are not able to see the slides?
Dr. Sengupta, no. Dr. Scheinman, can you actually reshare your slides from the Zoom?
Reshare the slides if you
can. I have done that. So here are my slides. I am here, share screen, correct?
Yes.
Yeah.
Okay, I've shared the screen. Okay. So this is okay. Here's my slides.
Perfect. So now you can go into this mode presentation.
Okay.
We are good. We are good. Perfect.
All good?
Yes, all good. Thank you.
Okay, no problem. So these are my disclosures. I want to begin with this introductory slide just to emphasize the specialized conducting system of the heart. So the electrical impulse begins in the sinus node region, which sits between the superior vena cava, and it's an epicardial structure right on the junction between SVC and the right atrium. And this emits electrical impulses, as you know, between 60 and 100 beats per minute. The impulses then are transmitted into the atrium, into atrial muscle. There really isn't any specialized tracks into atrial muscle. Bathes the AV node, the common bundle, and then you can see there's a specific set of fibers that come down, a single set. This is the right bundle branch. And then on the left side of the septum, you have the left bundle, which is a lot more complicated because it splits off into 2 or more fascicles to supply the left ventricle. So the electrical activity is determined by the specialized conducting system, and the EKG that we look at, the surface, consists of the P wave, which is the polarization of the atrium, and we're going to focus on the PR interval, which is the interval that links atrial depolarization with ventricular depolarization, as is shown here. So these are the fundamentals. Now, one very important point to emphasize is that now we have the ability to actually record potentials from the heart. This is the advance by originally by Dr. Sherlock, which allowed for us to be able to take a multipolar electrode catheter, position it across the tricuspid valve, and actually record from the His bundle itself. Now, this turned out to be very important because if you look at the ordinary ECG, you have a P wave, PR interval, and the QRS. But this is really divided up into sub-intervals, mainly an A to H interval, which denotes conduction from the low right atrium across the AV node to the His. The AH interval is reflective of AV nodal conduction. The H to V interval is the interval from the His depolarization to ventricular activation. Now notice that normally AV nodal conduction is much slower than infranodal conduction. This is because of the type of cells that are involved and the type of currents that they carry. So, for example, the sinus node, AV node are predominantly calcium current dependent, whereas infranodal tissue, myocardial tissue, atrial tissue are fast sodium channel dependent. Conduction much more rapid. Things to remember is that the normal A to H is from 60 to 120 milliseconds. The HV is much shorter, 35 to 55. So once the impulse gets to the His, it rapidly shoots to the ventricle. And that's going to be important when we talk about the importance of the PR interval in assessing site of block. And this is another important point to remember for clinicians. The real issue is, where is the site of block? Is it at the level of the node, or if it's infranodal? We know that infranodal carries a much higher significant adverse prognostic indications compared to nodal block. So we're very keen to try to decide on the basis of the ECG findings whether the block is at the node or below the node. Okay, now phenomenologically, classically, the AV blocks have been segregated into three categories: first degree, second degree, third degree AV block. Okay, as I said, this is just a phenomenologic categorization. The important thing is to try to discern where the level of block is. So let's start with first degree AV block, and this is defined as prolongation of the PR interval. Now, the PR interval for normal heart rates is no more than 5 small boxes or 1 big box. Now, each little box is 40 milliseconds. So the upper limits of normal of the PR interval at normal heart rates is 200 milliseconds. You can see here, PR interval is almost double that. So it's prolonged. So you have a narrow QRS, long PR interval, and this is called first degree AV block. Now, first degree AV block, normal QRS, long PR interval. This is very common and is always associated with block or delayed conduction in the AV node, and doesn't need any particular treatment if the patient's asymptomatic. Second degree AV block, on the other hand, is divided up into 2 separate categories. One category is known as Mobitz I AV block or Wenckebach conduction. They're the same. Mobitz I, same as Wenckebach. And in order to sort out the AV blocks, it's well to remember 3 basic rules. Okay, rule 1 is identify the P wave. Okay, by identify the P wave, we say look at its rate, its regularity, and its morphology. Now, normally, as we know, the heart rate is between 60 and 100 beats per minute. when the sinus node discharges, it's usually quite regular, maybe irregular for some people who have respiratory sinus or arrhythmias, but by and large, they're fairly regular. And normally, each QRS is preceded by a P wave. In second degree AV block, the thing that you notice straight away is there are P waves and no QRS. P wave, no QRS. The second rule is look at the QRS. Is it wide or narrow? So look here, and this is a narrow QRS. Narrow QRS is defined as a QRS less than 3 small boxes, less than 120. So that's the second rule. First rule, identify the P waves, look at its rate, regularity, morphology. Rule 2, look at the QRS. Is it skinny? Is it narrow? Or is it wide? This is narrow. Third rule is look at the relationship of the P wave to the QRS. And here you notice a very characteristic phenomena. The PR interval increases prior to the drop beat. So you have progressive prolongation of the PR interval before the drop beat, and then it starts all over again. So this is known as Wenckebach conduction. Wenckebach conduction. Progressive prolongation, the PR interval, drop beat. Now, let's spend a moment on Wenckebach, because Wenckebach conduction can occur anywhere in the heart. And so that's why it's very important to be able to identify this phenomena. Now, when you have an indication of what's going into the system, namely atrial depolarization, and then what's coming out, namely ventricular, then it becomes easy to discern the presence of Wenckebach. As we said before, you get progressive prolongation of the PR interval and then a drop beat and start all over again. But you could have conduction within the junction, for example, that can have Wenckebach block, where you just see what's coming out of the system. You don't see what's going in. And this could still be Wenckebach. Now, the way to determine Wenckebach conduction is by various looking at various phenomena associated with Wenckebach. And to understand this, we go back to the atrium, which is firing at a regular rate, let's say 800 milliseconds. It's discharging. The impulse goes through the AV node. This is the first beat of the Wenckebach cycle. So this is the shortest PR interval, 0.18, and it fires the ventricle. The next sinus beat fires, and the degree of prolongation of the PR interval is 60 milliseconds. The PR interval prolongation is greatest in the first cycle. That's how it is with Wenckebach. First cycle has the greatest prolongation. So if the prolongation is 60 milliseconds, then if you look at the PP interval, that's 800 milliseconds. If you look at the change in PR, that's 60 milliseconds. Therefore, the ventricular rate, let's call it the RR interval, will be 0.86, because it's the atrial rate plus the change in PR. That gives you 0.86. Now, let's look at the subsequent beats in the Wenckebach cycle. Let's take the second cycle of Wenckebach. Now, when you measure it on your EKG paper, the PR will get longer, okay? But the degree of prolongation is less. So in this hypothetical example, it incremented by 20 milliseconds. So again, if we look at the atrial rate, that stays the same. The delta PR, however, has changed. Instead of being 60 milliseconds, it's only 20 milliseconds. So the RR interval is 0.82. Let's take the next beat in the Wenckebach cycle, the beat that terminates the Wenckebach cycle, the beat that introduces the pause. That one, again, PR interval will lengthen. Degree of lengthening becomes even less. So here it's only 10 milliseconds. So again, you'll measure the PR, and the PR will measure a little longer compared to the preceding one. But if you measure the RR interval compared to the atrial, it'll only be 0.81. So one feature of Wenckebach is the ventricular rate becomes long, short, short. So as you progress along a typical Wenckebach cycle, the ventricular rate becomes progressively shorter. That's one feature of Wenckebach. The second feature is shown here. The beat that introduces the pause has the longest PR interval. After the pause, you have a rest period, and you can have facilitated nodal conduction, so that the pause is in effect curtailed by the fact that the beat that introduces the pause is very long. The beat that terminates the pause is very short, so that the pause is always less than twice the shortest RR because of this configuration. So those are the two features of the Wenckebach tract. Look at the RR. The RR goes long, short, short. Pause less than twice the shortest RR. Now, another type of type 2 block is Mobitz II block. And here I purposely recorded it at a very rapid paper speed. And we look at the three rules. So rule 1 is identify the P wave. Okay, we see a P wave, P wave. We look at the QRS. Here you'll have to take my word for it, because this recording is 4 times faster than you're used to looking at it. This is a wide QRS. So there's a fixed P interval. QRS is wide. Let's look at relationship. PR is constant. PR is constant. Suddenly, you have a drop P wave. Okay. Now, if you look at the intracardiac recordings, you'll notice that in the first beat, shown here, the A to H interval is perfectly normal, 76 milliseconds. We said AH 60 to 120 is normal. So so the impulse can zip right through the AV node. But look at the HV. Your HV is 76. It's far above the upper limits of normal, which is in the range of 55 milliseconds. So the impulse is able to navigate from the atrium to the ventricle, but there is disease in the infranodal conduction system. Now, let's look at the block beat. Block beat has a sinus P wave, which conducts to the His. That doesn't surprise you because you have normal AV node conduction, but the block occurs distal to the His. So this is Mobitz II. Mobitz II block denotes block in the infranodal conducting system, and these patients need a pacemaker. Even if you've seen 1 in 100 of these patients get a permanent pacemaker. The reason for it is this, that patients with Mobitz II block can sail along, as we can see here, in sinus rhythm, is conducted. So the P waves are constant. QRS, notice, is wide. It has an RR prime in V1, so it's a right bundle branch block pattern. So the right bundle is gone. PR is constant, and then suddenly you have a drop beat, and then you have ventricular asystole. And this is the cause of Stokes-Adams attacks, where these patients can suddenly fall, and mercifully, most of the time, an escape ventricular pacemaker will take over. But these patients can have ischemia and have sudden cardiac death due to ventricular fibrillation. So this is why it's important to discern evidence of infranodal disease, and these patients require a pacemaking. So review, Mobitz I, progressive prolongation of the PR interval, followed by a drop beat. Mobitz II, fixed PR interval, or at least 2 conducted beats before the complex, and then a block beat. Okay, so I hope this is clear. Mobitz I, Mobitz II. Okay, so let's look at this. Whoops. Let's look at this. Here's a patient who comes in with blocked P waves. Okay, so immediately we know it's second-degree AV block. Okay, we apply our rules. You see P waves. Here's a P wave. Here's one. Here's one. This rhythm is slightly irregular. The PP interval that sandwiches the QRS turns out to be shorter, but we don't need to go into it. But there's a good reason for that, but we don't have the time to go into that during this session. Let's assume the PP interval is reasonably regular. Okay, QRS is wide, greater than 3 little boxes. Pattern RR prime, so right bundle. Relationship. Notice that every other P wave is blocked. Conducted, blocked, conducted, blocked. So this would be 2-to-1 AV block. When you see 2-to-1 AV block, it's neither Wenckebach nor Mobitz II. So you can't be entirely sure just by looking at this where the block occurs. Now notice the PR interval is normal, which is a strong hint that the block is in fact infranodal. The other hint is you have right bundle branch block, in other words, the right bundle is gone. So it may be that there's disease in the left bundle that gives you the 2-to-1. Now there are bedside maneuvers that help us discern the level of the block, because it's not just an academic exercise. Oh, it's 2-to-1 AV block. You know, are you going to intervene and put a pacemaker in this patient? We'll go into certain maneuvers that are helpful. Now, the last of the degrees of AV block that we're going to discuss is complete AV block. Now here, again, you use the rules. P waves are regular, marching right on through. QRS here happens to be skinny, narrow. And notice that the ventricular rate is much slower, and it's constant. And this is how you diagnose complete AV block. The atrial rate and the ventricular rate are completely unglued, and the atrial rate is more rapid than the ventricular response. So this is 3rd degree or complete AV block. Where the level of the block is depends on the narrowness of the QRS and where it comes from. So if it's a narrow QRS, it comes from the junction. If it's a wide QRS, it can come from the fascicles or the ventricle. It comes from the ventricle, the rate is oftentimes much slower. Now, in terms of 2-to-1 block and use of various maneuvers, this is a very important illustration of these maneuvers. So this is a patient who came in with a history of syncope, and the nurses gave me this strip. This is V1. And so the P waves are present and regular, march right in order. Okay. The QRS is wide, again, a right bundle. We'll show you examples of left bundle later, but this is right bundle. And again, we notice conducted block, conducted block. So this is 2-to-1 AV block. Now, when you see 2-to-1 block, one trick to use at the bedside is you can do carotid massage. Now remember, when you do carotid massage, always listen over the carotid. Make sure that the patient doesn't have carotid stenosis. So if there's no bruit, it's perfectly safe to, whoops, this is not my doing. It's just, okay. It did it by itself. Anyway, with carotid massage, notice here, the sinus rate slows, which is what you would expect. With carotid massage, you expect slowing of the sinus rate and prolongation of the PR interval or block at the level of the node. Now, interestingly here, with slowing of the heart rate, look at what happened to conduction. You improve conduction. So if you have a situation where patient comes in with syncope, dizzy spells, and they have varying degrees of AV block, that's not particularly that's not diagnostic of Wenckebach or Mobitz II. Then one maneuver is to do carotid massage, slow the heart rate, and if conduction improves, this connotes disease in the His-Purkinje system. And what's happening is, as you slow the rate, now the His-Purkinje system can accept these impulses. See, at this rate, it says, I can't handle it. I can only handle every other P wave. At this rate, I can handle 1-to-1. In contrast, if this was AV nodal block with carotid massage, it should have gotten worse. And then also notice that when you stop carotid massage, it goes right back into 2-to-1. And this is important because it makes the other point. So in other words, a patient comes into your office with a history of syncope and they're conducting 1-to-1. And one trick is to try and speed up the heart rate. Okay? Have them stand up quickly or put them on a treadmill, have them exercise. And if with increasing heart rate, you start dropping beats, be very suspicious of infranodal disease. Okay, so if you have carotid massage, improve conduction, infranodal. If you have exercise-induced block, think of infranodal. Okay, so review. First degree AV block, narrow, almost always at the node. Mobitz I, narrow QRX, again, almost always at the node. Now that's important because if a patient comes in with Mobitz I and you're at narrow QRS, you're almost sure that this is going to be at the AV node. And what you need to do is to say, well, what's the cause of it? So the common causes are drugs. Nowadays, we have a whole variety of drugs that can block at the AV node, namely digitalis, calcium channel blockers, beta blockers. So you may have to stop or change the dose. Alternatively, hypervagatonia will give you Mobitz I or Wenckebach block. This is very common, particularly in athletes. They go to sleep, and about 20% of them will have episodes of Mobitz I. That's perfectly physiological, not to do anything because of that. In contrast, Mobitz II block, Okay, this is when you have fixed PR and then a drop beat. Whether it's narrow or wide, this is infranodal. Now, you can have Mobitz II with a narrow QRS. It's very uncommon. This will be block in the His bundle itself. So whatever comes out of the His bundle is skinny. Mobitz II wide is always infranodal. Okay. If you have fixed block, then you can't use the Mobitz rules. Mobitz rules are only when you have a situation where you have a constant PP interval, and either you have a situation where you have partial prolongation of the PR before the block, or two conducted beats and then a block, which is Mobitz II. If you have fixed block, you can't tell. However, if it's wide, as we showed you, suspect infranodal disease. Third degree AV block, this is where no atrial impulse gets through to the ventricle. It could be either wide or narrow, depending where the escape is. If the escape is high in the junction, you can get a faster rate than if the escape is in the ventricle. Now, one thing to bring out is the fact that the left bundle divides into at least two, and in most of humans into three fascicles. But let's talk about the two fascicles. There's an anterior fascicle and a posterior fascicle. And the most common cause of so-called bifascicular block is block in the right bundle, because that's long and slender. And then also block in the anterior fascicle, because that tends to be thinner than the posterior fascicle. So these are the most common causes of so-called bifascicular block. In other words, block in at least two of the three fascicles. And this is shown here. So if you look at lead V1, you see a right bundle pattern. So we know the right bundle is blocked. And then in one of the features of fascicular block, left anterior fascicle block, is that the initial forces go to the right, negative in 1, positive in 3, the right and inferior. Terminal forces are way off superior, left and off to superior. So bifascicular block pattern makes you think, if someone comes in with syncope and they have this pattern, think of episodic block, infranodal block. So here's a way in which we use these kinds of concepts for patient management. This is a woman who had a syncopal episode, and we monitored her in the hospital. We couldn't find anything. And so if you have unexplained syncope, one reasonable approach is to do a His bundle study to find out exactly where it is. So again, this is recorded at a rapid speed. So take my word for it. There is a P wave here. I know that because there's an atrial deflection here. So there's a P wave, and there's a long PR interval. And then this is a left bundle branch block. You see pattern. There's a small R and a deep S. The left ventricle is the posterior ventricle. Left ventricle is the posterior ventricle. And so when it is activated, the terminal forces will go towards the blocked ventricle. Right? So the patient stayed in this pattern, first degree AV block, left bundle. Now look at the His bundle study. The A to H is 170. That's markedly prolonged. Look at the HV. HV is almost double upper limits of normal. It's 100 milliseconds. Okay, so the patient had disease both above, both at the nodal level and below the AV node, the His Purkinje level. Now, our own studies have shown that if you have an HV of 100, you're 14 times more likely to spontaneously develop complete AV block or sudden death. So this is important, and this is in the guidelines. If you have a prolonged HV interval, you get a pacemaker, particularly if the HV interval is greater than 70, because that's when the risk takes off. Now, the other thing that's done in the lab is shown here. So here we had a gentleman came in with syncope in the emergency room. And if you look here, this is V1. He comes in with a right bundle. This is lead 2, a markedly superior axis. So very alert resident said, well, we have to come into the hospital for monitoring. So he was monitored, didn't find anything. This bundle study shows HV of 40 milliseconds, which is perfectly normal. Okay, but instead of saying, okay, pick up your hat, you're ready to go home, what you do is you have to stress the His-Purkinje system by increasing the heart rate. So here we're pacing at a cycle length of 600, which is just a heart rate of 100. Okay, so at this heart rate, notice this is the stimulus. It conducts to the ventricle. Stimulus to the ventricle. This stimulus conducts to the ventricle. Here's the stimulus pacing the atrium. Nothing. Look at your His bundle recording. You have stimulus. You pace the A. It goes in the His, then it dies infranodal. Okay, so this is proof of infranodal disease, and the patient gets a pacemaker. Now, I would like to spend some time on the concept of unusual presentations of infranodal block. You don't want to miss these, because these are the patients that could be helped a great deal by pacing. So, number one, recognition of the importance of bilateral bundle branch disease. So the patient comes in with spontaneous right bundle, left bundle. Both bundles are involved. These patients need a pacemaker. If you have paroxysmal AV block, I'll show you it in a moment, these patients need a pacemaker. AV block with a narrow QRS and a normal PR interval, they need a pacemaker. Wenckebach with bundle branch block can either be at the node or below the node, and they need further study. Okay, so let's go through this. So here's a patient who is this interesting pacing. P waves are regular. P waves are regular. Okay. If we look at the pattern, QRS, this is a left bundle. Yes. This is a RR prime. This is a right bundle. Excuse me. So this patient has bilateral bundle branch disease. Immediately, we're worried about this patient. Now, look at this. The PR interval begins off normal. It gets longer, drop beat. This is Wenckebach. Okay, but this is illustrative of a very important point. You can have Wenckebach conduction in a very, very sick His-Purkinje system. It begins to act like an AV node. Your sodium channel occurrence are amiss due to genetic abnormalities or functional structural abnormalities. You can get Wenckebach type conduction in the His-Purkinje system. So Wenckebach, narrow QRS, almost always in the AV node. Wenckebach, wide QRS, you can't tell, and you need more information. So more information could be exercise to bring out. If exercise sometimes doesn't work appropriately, you do the His bundle studies. That always sorts these things out. Okay, now here's another important and fairly common presentation. Here's a patient who comes in, again, with periods of AV block. So it's type 2. Type 2 is an incomplete diagnosis. You have to keep working at it. So we notice it. PR interval is normal. And the QRS is narrow. The other feature about the QRS here is that the, well, correction. So anyway, QRS is narrow. Relationship, there's a 2-to-1 relationship between atrial and ventricular response. Notice that the PR is constant and is normal. And this is pathognomonic of infranodal block, because in infranodal block, normally your HV is very short. It's in the order of 35, 40 milliseconds. So if you increase it even by 50 milliseconds, it'll still give you a normal PR interval. So a big clue to the site of block is look at the conducted PR interval. If that's normal, suspect infranodal disease. Okay, one other feature that suggests infranodal disease. Here's a patient sailing along sinus rhythm, 1-to-1 conduction. Suddenly you have a PVC that triggers complete AV block. Okay, this is known as paroxysmal AV block. Paroxysmal AV block. Now, this is a beautiful study by Lee and Wellens and Josephson, some of the heroes of electrophysiology. And they point to the prior work of Hoffman, where they show that in a normal His-Purkinje system, you fire the ventricle or the His-Purkinje tissue, and then it comes back to normal, and it stays there at a level of about -80, -90 millivolts. It stays here until you depolarize it, the sinus node, or from an artificial pacemaker. Okay, you fire it, and it'll stay this way. And if you put in a premature beat, what happens is you'll have a pause, but during the pause, there's really very little change in action potential during the quiescent phase. Now, if in disease His-Purkinje system, what was shown in animal preparations is you put in a PVC, and instead of the resting potential hanging in there at the normal level, -80, -90, it drifts upward. So then when the next P wave comes, instead of firing normally at -80, it's here and it's at a range where the ventricle is non-responsive. So this is paroxysmal AV block. This is another indication of infranodal disease. Okay, so in summary, if you see bilateral bundle branch block, intermittent block with normal PR conducted beat, paroxysmal AV block, and this is known as phase 4 block, bedside maneuvers that we talked about, carotid massage, if they come in with block and if it improves, infranodal. If they're 1-to-1 and you exercise and they start blocking, infranodal. Okay, so these are important rules to remember. Now, in the remaining minutes, I want to talk about some new treatments for patients with AV block. First, I want to say a few words about vasovagal syncope, because we would be remiss for not talking about it, because it's the most common cause of syncope. And it's oftentimes triggered by standing, and one maneuver that's used in the lab is the so-called tilt table test, where you can acutely tilt people. And when that happens, you pool blood to the abdomen and the legs, largely the abdomen. There's decrease in venous pressure, decrease in filling pressure, decrease in blood pressure while this occurs, and then this activates the autonomic nervous system. This activates the sympathetics to increase the heart rate and to increase the blood pressure to counter the effects of standing. Now, in some people, the initial sympathetic effect is counterbalanced by a very strong parasympathetic effect. So a couple of things to remember about the autonomic nervous system. So the centers are at the base of the brain, and the sympathetics that come out along the spinal cord, and their synapsis occurs in a chain of ganglion that are parallel to the cord, and then they go to various organs. And for our instances, we're going to emphasize the effects on the heart. Okay, so they tend to accelerate the heart rate and increase the blood pressure. On the other hand, the vagus, and so this has its synapses far from the heart. The vagus outflow tends to slow the heartbeat and increase the PR interval. The important thing to remember is that the synapses for the vagal lie within the cardiac tissue itself. There are ganglionoid plexi in the heart, which controls heart rate and PR interval. So in general, because you'll see vasovagal symptoms all the time, we tell our patients to keep well hydrated, avoid diuretics, vasodilators, and the known triggers for vasovagal. So that's general. Now, a couple of things that have been learned over the years is the importance of counter pressure. So if you have a patient who has venous pooling, what we ask them to do is squeeze their hands very, very tightly. If they're standing, they cross their legs with simultaneous tensing of leg and abdominal muscles. All of this tends to decrease the venous pooling. Grip a handball, arm tensing one hand against the other, get them in a supine position with legs raised. I think these are really very important. Oftentimes, this and the general recommendations that we made is all you need for treatment. You can use compression socks and binders for people who have repeated episodes. Compression socks alone is not sufficient because it's just minimal third spacing. So you need support hose that go up to the waist. In the patients who are predominantly have syncope due to a chronotropic response, in other words, a situation where you have increased vagal discharge and then complete AV block with slow or no ventricular response. Here, pacemakers have been shown to be helpful, and then there's these newer systems, which are closed loop systems, where you can detect right ventricular impedance and can initiate pacing early on. And this is shown to be very effective. Other pacing systems have rate drops. In other words, when it sees the sinus rate drop, it starts pacing right away. It's important to remember, if you're putting patients with vasovagal syncope, it's important to remember that these patients may have a concurrent vasodepressor response, because when you activate the vagus, you slow the heart rate, but you also have vasodilatation. So they may, in spite of pacing, they may still be symptomatic. You have to warn them about that. Drugs for vasovagal, fludrocortisone actually has been shown to have minimal benefit. Drugs like beta blockers and SSRIs are not beneficial. Midodrine is clearly effective, but you got to be very careful using it, particularly older people with hypertension, because this is an alpha agonist, and this will increase your blood pressure. So theophylline in small trials have been benefit. We started a trial many years ago it is effective, but the patients don't like it because their heart rates tend to be on the fast side, and so it's hard for them to rest. Okay, this is a 22-year-old runner that we had, and the patient was tried on all the usual maneuvers, and EKGs showed these periods of pauses, which were symptomatic. And there is a new technique where one can go in and actually identify where these ganglionated plexi are and ablate them. And this is just an example of where these ganglionated plexi may live. They usually live around the pulmonary veins. And with varying techniques, you can record fractionated potentials over there, or you can apply radio high frequency discharges, and this will discharge the vagus, and you're over the ganglia, and then apply radio frequency. And just to show you what occurred in this patient when there was the first radio frequency, you can see your heart rate sped up as you depressed vagal function. In the last few minutes, I just want to say a word about the newer things related to cardiac resynchronization therapy. We know that patients with heart failure and left bundle branch block can benefit from resynchronization therapy, which is pacing from the right ventricular apex or septum, as well as putting a coronary sinus lead to activate the LV. So you synchronize LV and RV, and most of these patients, about 2/3, will get better. The newer techniques allow for pacing of either the his bundle itself, or now the left bundle. You put a catheter and tunnel it through the septum and actually activate the left bundle. And this can be done by means of carefully monitoring tip impedance, and also looking at the electrogram. And then surface you pace until you can see a right bundle. So if you activate the left bundle very quickly, you'll have a right bundle branch block pattern, which is what you see here. So these are the ways in which it's done. I don't want to emphasize the technology. His bundle pacing is largely bypassed because it turned out to be technically more difficult. There's a high capture threshold, increased lead, premature battery failure, loss of his capture. So nowadays, most people are using left bundle pacing, and this is a nice example of one where you have pacing, and you can see this is left bundle pacing, and you can see how nice and skinny, narrow the QRS looks like. And the preliminary data suggests that if you look at all possible outcomes, all-cause heart failure, the left bundle pacing is even better than the biventricular pacing. So I think I shall stop now. I thank you for your patience, and I'm happy to participate in the discussion.
Thank you very much, Dr. Scheinman. That was an excellent coverage, and particularly for our trainees and some of us, it has been a good refresher to go through all the details. So now I'd like to bring Dr. Costas and Dr. Tegmaglione and Dr. Karamelis, if Jim, you're able to join us, to have a small panel discussion. Bill?
So thank you, Dr. Scheinman. What an excellent talk, and it's a thrill, I'm sure, for our trainees and others to hear a presentation given by such a legend in cardiac electrophysiology. I just had two questions. One of them is sort of a historical context question, and the other one is more modern. Maybe I'll just start with the old one. So your treatment of second-degree AV block and Mobitz I and Mobitz II, in particular for our trainees, was perfect and classical. And what I often found interesting is if you look at the studies in the 70s, it turns out that there was a fair amount of data in the late 70s to show that the so-called typical Wenckebach periodicity, in other words, that the delta PR would be shrinking, was not often the common case, in particular with long Wenckebach cycles. And I was wondering if you have some thoughts as to why that might be, just differing fibers in the AV node or something else. And the second question is where you see conduction system pacing going now that we have preliminary data from Pennsylvania and other centers that it may actually be better for ventricular synchronization than CRT.
Yeah, so beginning with your second point, yeah, I fully agree. It looks like left bundle pacing is the way to go. It's clearly more effective long term than the his bundle pacing for the reasons that we talked about, and I think that's the standard. And nowadays, at least in our center, even if the patient doesn't have heart failure, but if it's going to be clear that the patient has a high burden, let's say greater than 30-40% of V pacing, then they get left bundle pacemaker put in. Now, as far as the atypical Wenckebach cycles, you're quite right. And I just didn't have the time to cover all the nice little points. But when you get above 5 to 4 Wenckebach, by 5 to 4, I mean 5 atrial impulses and 4 ventricular. So if you're looking at 4 to 3, 5 to 4, you'll see typical patterns. Once you get above that, the usual is the atypical. And that's a really important point, because if you just catch the tail end of a long Wenckebach cycle, it can mimic Mobitz II. I've seen this over and over again by good people. They look at the last few and they say, oh my goodness, this looks like it's constant. But you have to go back over the initial ones. Why it happens, I don't know. And I haven't heard of any good explanation. Maybe.
Well, if you don't know, probably no one knows.
No, I don't know.
Jim?
Hi, thanks, Mel. Wonderful as always. Thinking back, it seems, I don't know if the experience at UCSF is different than at Robert Wood Johnson at Rutgers, but I think the fellows, the bane of their existence is often heart blocks coming into the ER. And, I suspect that the numbers are close and maybe even greater than the number of acute MIs that we get. But the approach, we don't really have a unified approach the way we do with the code MI to how to treat this. So it's a very heterogeneous approach. EP studies, which you shown are very valuable, are not done for many good reasons. And I was wondering if you had any thoughts about whether there should be a more systemized algorithmic approach to the common problem of AV block in the ER.
Yeah, I think that's a good point. I think that the simple bedside maneuvers are really important. It's so easy. I see this over and over again. Someone comes in with syncope and the cause is not obvious. So either they say, oh, you were dehydrated. Dehydration, it seems to be like a catch-all, it's like an epidemic, and I can't tell you how many times people are in the emergency room and they're sloughed off, and it's so easy. I mean, all you need to do is those simple things. If they come in with some degree of AV block, then a little massage, providing it's safe, or bedside exercise can sort that out. So I think I agree with you. It's oftentimes not thought of, but there are simple bedside maneuvers, as you know, that can be very helpful.
Ed?
It's good to see you, Jim.
Same here.
Yeah, the last time I saw him was in the heart rhythm.
Dr. Scheinman, that was an outstanding lecture. I've heard you speak many times throughout the years, and every time I learn something new. It's an amazing talk. I know you briefly spoke about it in your lecture, but for vasovagal syncope, it seems to be a condition that is unfortunately very tough to treat. And there's been mixed results with pacemakers. I know one of the manufacturers does have that closed loop system, which has had some results in extreme cases of vasovagal syncope. Do you think that neurocardial ablation is something that's perhaps underutilized and something we should maybe have a lower threshold to try to incorporate in treating these patients, since here we're actually directly targeting the autonomic system and trying to manipulate it to really mitigate some of the effects? Because I know with the pacemakers, it doesn't really get rid of the blood pressure drops, which sometimes make even increasing the heart rate really not as effective.
Yeah, all good points. Our own personal experience is very limited. We've got maybe a half dozen done. So far, it looks pretty good, and the emerging data from the literature looks very promising. So it's a relatively it's a sort of a new kid on the block. I don't have a lot of strong personal experience with it, so that's why I hesitate to give it my imprimatur. But the latest articles and reviews look pretty promising, even for older people. I saw a nice article recently in Heart Rhythm, for example, showing benefit even in older folks with vasovagal.
Okay.
Fantastic, great. I think we had a wonderful coverage, and also it's wonderful to see all our electrophysiology colleagues together. So thanks, Jim, for joining. Phil, Ted, thanks, and Dr. Scheinman. And we look forward to continuously learning. This field seems to be the basic foundation of cardiology that we visited has not changed, which is good. But there's a lot more that is going on, and as Jim was correctly pointing out, of how do we organize and bring back the basic foundational elements of inquiry in these patients, like in the ED and other places, which can be done fairly easily without requiring lots of gadgets. I think it looks like we run for technology more often versus the medical intuition and medical diligence and trying to get the facets elicited at the patient at the bedside may be more useful. I think I second that, and I thank for reinforcing that, particularly for our trainees. With that, thank you for this wonderful lecture, and we look forward to probably having you again, perhaps in person.
My pleasure.
Yes. Bye-bye.
Bye-bye. Very nice seeing all of you.
Thank you.
Thank you for your invitation.